Hello, everyone, and welcome to this presentation on concepts of care for patients with hypersensitivity and autoimmunity. I'm excited to share this information with you today. Let's dive right in. In this chapter, we'll focus on two key concepts: immunity and inflammation. Understanding how these processes work and sometimes don't work is crucial for providing effective care. We'll also explore the interrelated concepts of gas exchange and tissue integrity. Immunity is the body's defense system, and inflammation is one of its key tools. But when these responses are exaggerated or misdirected, they can cause harm instead of healing. That's where autoimmune diseases and hypersensitivities come into play, and as nurses, knowing the balance is key. Our objectives today are to discuss the pathophysiology and clinical manifestations of rheumatoid arthritis and lupus erythematosus. We'll prioritize nursing care for clients with autoimmune disorders, including drug therapy, and identify concerns of clients with immune disorders. Allergic reactions can manifest in various ways. From a healthcare perspective, we look for cardiovascular, skin, digestive, and respiratory symptoms. Children might describe these symptoms differently, focusing on how they feel. Hypersensitivity reactions are classified into four types. Type Y is IgE mediated, leading to anaphylaxis. Type 2 is cytotoxic, causing conditions like hemolytic anemia. Type 3 involves immune complexes, leading to serum sickness. Type I hypersensitivity, also known as rapid hypersensitivity or atopic allergy, is the most common type. It results from increased production of IgE antibodies and can manifest as hay fever, allergic asthma, or anaphylaxis. Allergens can enter the body through various routes: inhalation, ingestion, injection, or contact with skin or mucous membranes. Common allergens include plant pollens, foods, drugs, and latex. Knowing the route of entry helps predict symptoms. Inhaled allergens trigger asthma, while ingested ones may lead to hives or GI upset. Histamine is a key player in inflammation. It contributes to the 5 cardinal signs: warmth, redness, swelling, pain, and decreased function. Understanding histamine's role is crucial for managing allergic reactions. Anaphylaxis is a medical emergency characterized by blood vessel dilation, decreased cardiac output, and bronchoconstriction. Symptoms can include respiratory distress, skin reactions, low blood pressure, and gastrointestinal issues. Type 2 cytotoxic reactions involve autoantibodies attacking cells with foreign proteins attached. This can lead to autoimmune diseases like autoimmune hemolytic anemia, Goodpasture syndrome, and myasthenia gravis. Type 3 immune complex reactions occur when excess antigens cause immune complexes to form in the blood. Many autoimmune disorders are caused by this type of reaction. These complexes get lodged in tissues like the kidneys or joints, causing inflammation and damage over time. Type IV delayed hypersensitivity is triggered by T lymphocytes. Antibodies and complement are not involved. Sensitized T cells release chemical mediators, causing edema, induration, ischemia, and tissue damage. Angioedema is a severe type I hypersensitivity reaction affecting blood vessels, skin layers, mucous membranes, and subcutaneous tissues. It can affect the lips, face, tongue, larynx, and neck. Because the airway can swell quickly, this is an emergency. Swelling may not look like much on the outside, but can silently block airflow. When assessing for angioedema, consider the patient's history, especially drug use for blood pressure control. Physical assessment should include checking for lip swelling, throat itching, and deep swelling of the face, lips, tongue, and neck. Interventions for angioedema include stopping the reaction, ensuring an adequate airway, and providing oxygen. Intubation or tracheostomy may be necessary, along with drug therapy. Anaphylaxis is a life-threatening type I hypersensitivity reaction. It's rapid, systemic, and can be fatal. Early recognition and intervention are crucial. It begins within minutes of exposure to the allergen, which is why time is of the essence. The sooner we recognize the signs, such as difficulty breathing, low blood pressure, or skin flushing, the better chance we have at preventing severe complications or even death. Immediate administration of epinephrine is the most important step, as it reverses airway constriction and improves circulation. Nurses must stay calm but act fast, notifying the provider and following emergency protocols. Health promotion and maintenance for anaphylaxis include avoiding known allergens, wearing a medical alert bracelet, and notifying healthcare personnel about allergies. Always carry an anaphylaxis kit or epinephrine injector. Initial symptoms of anaphylaxis can be subtle. Look for feelings of apprehension, weakness, and impending doom. Respiratory symptoms and hypotension are also key indicators. These early signs are often overlooked or mistaken for anxiety, but they are red flags that a systemic reaction is starting. Patients may say things like, "I feel weird," or "something's wrong." As nurses, we need to trust those gut feelings and perform quick, head-to-toe assessments. Monitor vital signs closely and be ready to escalate care immediately if signs worsen. Assessment of allergic reactions often involves observing skin manifestations like rashes and hives. These can be intensely itchy and uncomfortable for the patient. Respiratory assessment is crucial in allergic reactions. Listen for wheezes, stridor, and signs of bronchospasm, dyspnea, cyanosis, and hypoxia. Breathing changes can signal airway narrowing or full obstruction. Stridor is especially alarming. It's a high-pitched, harsh sound that means the upper airway is closing. Cyanosis or bluish skin indicates oxygen deprivation. These symptoms require immediate oxygen support and possibly intubation. Nurses should always have emergency respiratory equipment ready, including suction and oxygen delivery systems. Interventions for anaphylaxis include establishing or stabilizing the airway, discontinuing any suspected IV drugs, calling the rapid response team, and applying oxygen. Be prepared to administer epinephrine and diphenhydramine. Treatment for severe allergic reactions may involve IV insertion for medication administration and potentially CPR if the patient experiences cardiac arrest. Having IV access ensures we can quickly give emergency drugs like corticosteroids or fluids to stabilize blood pressure. If the reaction leads to shock or respiratory collapse, CPR may be necessary. Nurses must be trained in basic and advanced life support, ready to act without delay. Medications and devices used in treatment include epinephrine autoinjectors, OVQ, EpiPen, diphenhydramine, and solumedrol. These are essential for managing anaphylaxis and angioedema. General autoimmunity involves the body's immune system attacking its own tissues. Antibodies or lymphocytes are directed against healthy cells and tissues, leading to chronic progressive disorders. The autoimmune response occurs when the immune system recognizes self-antigens as foreign. This triggers a cascade of immune reactions, leading to tissue damage. Think of it as the body mistakenly going to war with itself. T cells and B cells, which normally protect us, begin attacking healthy organs and systems. The result is inflammation that can manifest in various ways: joint pain in RA, kidney issues in lupus, or nerve damage in MS. Understanding this cascade helps nurses educate patients about why symptoms fluctuate and why long-term treatment is needed. Warning signs of autoimmune disease include fatigue, difficulty concentrating, muscle or joint pain, hair loss, dry eyes, mouth, skin, unexplained weight changes, numbness, abdominal pain, rashes, and multiple miscarriages. Autoimmunity is a process where the body recognizes self-antigens as foreign and produces antibodies against its own tissue. Examples include lupus and rheumatoid arthritis. It's like the immune system gets confused. It sees normal tissues as threats and attacks them. This abnormal recognition is what fuels chronic inflammation in autoimmune diseases. With lupus, multiple organs can be affected, while RA mainly targets joints but can also be systemic. Understanding this misrecognition helps us grasp why these diseases flare up, require long-term management, and don't have a one-size-fits-all treatment. Rheumatoid arthritis is an autoimmune disease characterized by inflammation, cartilage damage, and vasculitis. The exact cause is unknown, but it's likely a combination of environmental and genetic factors. Assessment of rheumatoid arthritis involves identifying early and late disease manifestations, as well as systemic complications. Joint deformities are a hallmark of the disease. Early symptoms include symmetrical joint swelling, fatigue, and low-grade fever. As it advances, you might see visible deformities like ulnar deviation or swan neck fingers. Assessing systemic effects, such as anemia, vasculitis, or even lung involvement, is just as important as tracking joint symptoms. Rheumatoid arthritis can cause significant deformities in the hands, including bent and deformed fingers, visible nodules, and joint swelling. These changes aren't just cosmetic, they severely affect the patient's ability to perform daily tasks like buttoning a shirt or gripping a pen. Nodules can also be painful or get infected. Nurses should assess function and pain regularly to guide rehab and therapy needs. In rheumatoid arthritis, the joint undergoes significant changes, including inflammation of the tendon, bone erosion, hyperplastic synovium, and thinning of cartilage. These changes make the joints unstable and painful. The synovium, which lines the joint, becomes inflamed and thickens, a condition called pannus. This eventually erodes bone and cartilage. These pathologic changes explain why pain worsens over time and why early drug therapy is critical. Diagnosis of rheumatoid arthritis involves several tests, including rheumatoid factor, RF, erythrocyte sedimentation rate, ESR, CRP, and serum immunoglobulins. These tests help confirm inflammation and the autoimmune nature of the disease. RF and anti-CCP antibodies are specific to RA, while ESR and CRP indicate ongoing inflammation. Lab results, combined with symptom assessments and imaging, give a clearer picture of disease activity. Nursing diagnostic priorities for rheumatoid arthritis include impaired physical mobility, chronic pain, and fatigue. Interventions should focus on managing these issues. Mobility issues affect independence and quality of life, so supporting patients through physical therapy, assistive devices, and energy conservation techniques is key. Fatigue can be overwhelming, so prioritizing rest periods and helping patients pace themselves is just as important as pain management. Pharmacologic management of rheumatoid arthritis includes NSAIDs for mild disease, corticosteroids for moderate to severe disease, and DMARDs and biologic response modifiers for more aggressive treatment. Care coordination and transition management for rheumatoid arthritis involve home care management, self-management education, and connecting patients with healthcare resources. Patients need a support system that includes occupational therapists, rheumatologists, and primary care providers. Teaching self-injection techniques, managing side effects, and understanding flare triggers all fall under nursing care. Connecting patients to support groups also helps with mental and emotional well-being. Evaluation of outcomes for rheumatoid arthritis includes achieving pain control, improving mobility and function, and verbalizing increased self-esteem. We measure progress not just by lab values, but by how well patients can return to their normal routines. Even small victories like being able to dress without assistance are meaningful indicators of improvement. Emotional support should not be overlooked. Living with a chronic illness can take a toll on mental health. Systemic lupus erythematosus, SLE, is a chronic, progressive autoimmune disorder. Tissue integrity is lost via excessive inflammation and overactive immunity, leading to organ failure and death. The pathology of SLE includes autoimmunity, exacerbations, vasculitis, and kidney involvement. It affects women aged 15 to 40 years more commonly than men. Assessment of SLE involves identifying symptoms such as skin involvement, butterfly rash, musculoskeletal changes, joint inflammation, and systemic symptoms, fever, fatigue, and organ involvement. Psychosocial assessment is crucial in SLE. Assess the patient's fear, anxiety, feelings about the disorder, coping mechanisms, and support systems. Laboratory and diagnostic assessments for SLE include ESR, serum complement levels, ANAs, anti-dsDNA, anti-ssDNA, anti-SM, anti-ENA, and blood and urine tests. These labs help confirm the diagnosis and monitor disease activity. Low complement levels often indicate active disease. Urine tests can detect early signs of kidney involvement, while anti-dsDNA antibodies are more specific to lupus. Analysis of cues and prioritization of hypotheses in SLE involve considering persistent pain, fatigue, potential for loss of tissue integrity and organ failure, and potential for decreased self-esteem. Planning and implementation for SLE involve managing persistent pain and fatigue, preventing organ failure, reducing SLE activity periods, and enhancing self-esteem. Lupus management includes lab tests similar to those for RA, such as ANA, ESR, complete blood count, immunologic testing, and renal tests. Routine monitoring helps guide medication changes and detect complications early. For example, anemia in CBC may indicate chronic inflammation, and renal labs help assess for lupus nephritis progression. Drug management for lupus includes NSAIDs and antimalarials for mild cases and prednisone for severe cases. Different types of cutaneous lupus erythematosus exist. Hydroxychloroquine is a common antimalarial used in lupus. It helps reduce joint and skin symptoms. Prednisone, while effective, must be used cautiously due to long-term side effects like weight gain, infections, and osteoporosis. Nurses need to monitor labs and educate patients about side effect management. Symptoms of systemic lupus erythematosus (SLE) can affect various organs, including the skin, heart, lungs, kidneys, muscles, and joints. This broad range of symptoms is why lupus is so difficult to diagnose early. One patient may have mostly joint pain, while another may present with chest pain or shortness of breath. Nurses must stay vigilant and think systemically when assessing these patients. Lupus education priorities include skin care, avoiding sun exposure using mild soap, stress reduction, managing fatigue, and recognizing signs of exacerbation, fever. Photosensitivity is a common issue, so patients should wear sunscreen and protective clothing. Stress is a known trigger, so we encourage relaxation, mindfulness, and balanced activity levels. Educating patients to report early signs of flare-ups can prevent complications. Care coordination and transition management for systemic lupus erythematosus involve home care management, self-management education, and healthcare resources. This includes teaching medication schedules, recognizing flare signs, and connecting patients with specialists like nephrologists or dermatologists. Nurses also coordinate follow-ups and ensure the patient understands when to seek emergency care. Evaluation outcomes for systemic lupus erythematosus SLE include understanding the disorder, accepting lifestyle changes, being an active partner in management, reducing pain, minimizing flares, remaining free from infection, and expressing a positive self-perception. Thank you for watching this presentation. Please subscribe, like, and share for more educational content. We hope you found this information helpful in your studies.